Hi, everybody. Welcome to our first Areitos Café Session of the year. My name is Julie, and I'm the Fractional Director of Programming and Development at Prospera Institute. We're super grateful to have you here for what promises to be an illuminating discussion. I'd like to give you a quick overview of how the cafe sessions are structured. In just a moment, I'll turn it over to Prospera Institute's founder and executive director, Joanne Suarez, for opening remarks and an introduction to today's panelists. We're honored to be joined by our friends at the O'Neill Institute Center for Health and Human Rights at Georgetown University, who will be leading today's discussion. At the end of the session, we will open the floor for a Q&A, followed by an optional feedback survey, which will be linked in the chat. Given the limited time, we may not be able to address every question, so we encourage you to share your thoughts and inquiries through the survey as well. And without further ado, please welcome Joanne Suarez.
Thank you, Julie, for the wonderful introduction. As Julie said, I'm Joanne Suarez. I'm the founder and executive director for Prospera Institute. Before we dive into the discussion, I would like to ground us in kind of a little story that led us today, that led me to what the spirit of these cafes are. So when I started my career in public health as a community health worker, a little bit over a decade ago, I actually entered community with the intention to listen and discern what would be the best way to respond to the issues that my clients were facing. And I remember being bright-eyed and bushy-tailed, ready to take on the world, as we typically are when we land our first jobs in the career paths that we desire. As a college student, I studied counseling psychology with aspirations of one day becoming a psychologist, but instead life took me on this journey on public health, where I eventually took on this second career as an ethicist. And as I immersed into my community, I found myself being pulled in by those areitos that my clients shared. And I specifically remember sitting across from one client that I will never forget. I sat with her every week for an hour at the corner of Mass and Cass, which is an avenue here in Boston, where there is a community of people that are homeless and are impacted by substance abuse and all kinds of systemic barriers. And in our one-on-one coordinating session, she had shared that prior to having a significant life event that took her down this path of drug use and eventually disability, she lived a full life as a nurse. And because of this unpredicted path to addiction, she lost her family and her home and all the things that were sacred to her. She resorted to a life of homelessness, which wasn't ideal, but it brought her great joy. And despite her circumstances, she was content because at least she had her basic necessities. She had food, clean water, a community shelter bed. But most importantly, she saw herself in the shared stories of the people that she lived beside on Mass and Cass. And in this areito of my client, I saw the faces of people that I was caring for outside of her, who had similar experiences. I saw and heard people in my family and in some ways myself. It was a repetition of their areitos and their stories that really captivated me. And I became deeply interested in questioning the things that make us human. I became interested in those social, cultural, and those political systems that press against us, eventually shaping our own areitos. I question in every story what would be the wrong or right thing to do, and how do we honor the humanity of the persons that's standing in front of us. And as I constantly thought about this and how I could take those areitos that were gifted to me and hold them with sacredness, make an impact for a greater good, I quickly learned that it was those stories that shape our collective conscious and our worldview, just like it did for the Tainos of the Caribbean and many of the communities that we occupy today. In ancient times, areitos were performed as sacred dances, songs, rituals, poems, and sharing of oral stories that became central to the people who we come from, those people that lived in tribal communities and have dispersed across the globe. These areitos were also central to daily political and religious life, and they were performed in central plazas on the premise of evoking a call and response from those who were participating in the tradition. These performed stories in their diverse fashions were responsible for shaping the moral societies that we live in today and the rules that governed them, designating who was the authority and who held power, and even dictating the processes that liberated some and oppressed others. It was this practice of areito that brought our ancestors through, and it's because of these areitos that we stand here today. When we started these fireside chat panels 5 years ago at ASBH, it was on the basis of sharing the experiences of the Latino communities that we belong to and uplifting some of the issues that impact their daily life and really uplifting their voices and their stories. So today we are honored to revive this tradition that is so sacred to the collective memory of not only Prospera Institute, but the people that we care for. Um, and I can't stress enough how significant it is for our organization to continue this tradition and honoring the spirits of where we come from. Areitos Cafe is for everyone, so we are happy to have all of you here. And as you listen to the speakers, please use the chat for interaction and discussion and put your thoughts and questions and reactions there as we now are in a virtual community in our own Areitos. And in the end, we will have a discussion, as Julie mentioned, as our own call to response into the Areitos that have been surfaced here. So without further ado, I want to pass it over to Natalia Guerrero, who is our moderator for the day and with Georgetown O'Neill Institute. And I will go on mute and listen. Thank you for being here.
Thank you so much, John, and welcome to everyone that's been joining. So I'm gonna start introducing the topic and then introducing our panelists today that we are very honored to have. We are also very happy to be collaborating with Prospera in this occasion. So I'm Natalia, as Joan said, I'm a lawyer, bioethicist, and a senior consultant for the Center for Health and Human Rights at the O'Neill Institute for National and Global Health at Georgetown University. The Center for Health and Human Rights works to improve the health through academic research and applied work that focuses on the nexus of health and national and international human rights law. We collaborate closely with local partners and build capacity, provide technical assistance, and pursue a strategic litigation on health and human rights, especially in Latin America. We have two lawyers as panelists, but don't worry that we won't be focusing a lot on the legal stuff. We are going to share some real cases from the region of Latin America. So we are very happy to have these panelists today. And just to start introducing the topic, why are we talking about this today? After some years have passed since the pandemic was declared, and this type of webinars or conversations used to be common during COVID. So why are we speaking about this today? So since the Ebola outbreak in 2016, the World Health Organization has repeatedly emphasized the importance and the need of preparing ourselves for resource shortage during public health crisis. The WHO has urged countries to establish clear guidelines for rationing health services, which is not limited to COVID, and it could apply to any other health emergencies. However, it was not until the COVID-19 pandemic that many countries faced large-scale health emergencies without well-defined protocols to guide decision-making in the rationing of healthcare resources. While some nations established national guidelines for prioritization of patients, others left the decision-making process to individual hospitals or even to individual healthcare professionals. So we saw during the pandemic various committees, commissions, health ministers, and academics all over the world proposing different frameworks for prioritization in the allocation of intensive care units, beds, or other critical resources. These frameworks, or some of these frameworks, however, often included discriminatory criteria that disproportionately affected vulnerable groups, specifically people with disabilities and older adults. We saw some controversial criteria that included, among others, things such as long-term survival, years of life remaining, quality of life assessments, life expectancy, functional independence, among other things. We are also familiar with the stories in the Lombardy region of Italy of doctors being forced to prioritize younger patients. We also saw some problematic criteria in the US. For example, in Alabama, we saw a protocol that specifically talked about severe mental retardation as a criteria. But also we have seen how the World Health Organization and PAHO, which is the Pan American Health Organization, emphasize the importance of setting clear ethical guidelines for rationing resources during public health emergencies. This included procedural safeguards that I'm sure Silvia is going to talk about. And from the international human rights law perspective, we also saw multiple UN bodies and in the Inter-American region also, strongly condemning any kind of discrimination against people with disabilities or older people during this healthcare prioritization crisis. So with this in mind, with this webinar, we want to reflect on this with some distance from the actual pandemic and think about if we are prepared to face another health emergencies and how we are prepared to do this. As bioethicist Joseph Estramondo has argued, triage or prioritization decisions are inevitably tragic. They are tragic choices. But they become even more tragic when we allow states to use inherently discriminatory categories or inherently discriminatory criteria. We believe there is a better way to do this, so this is why we want to share these experiences with you. This webinar seeks to share experiences from Latin America. Specifically, we will have two panelists reflecting on concrete cases in Colombia and Chile that we are currently where petitioners or people, real people, have demanded protection because they have a disability, they are older people, or they have chronic health conditions, and their rights were being threatened or were violated because of this lack of clear guidelines or the existence of problematic guidelines. So using legal and bioethical lenses, our panelists today will share the lessons learned from these two real life experiences. And we also want to invite the people here, the public here, to share their perceptions and experiences from their own context that could provide a better understanding on how to respond better to future emergencies in the US and also in Latin America. So I'm gonna start with Silvia. I'm gonna put her in the spotlight in a second, but I wanna introduce Silvia first. Silvia is the co-director of the Center for Health and Human Rights at the O'Neill Institute. That's the same place where I work, Georgetown University. Before joining the O'Neill Institute, Silvia was an attorney and the executive secretary of the Inter-American Commission of Human Rights for 14 years, where she managed multiple merit stage cases regarding the member states of the Organization of the Americas. She also supervised the preparation of the reports on the merits. Silvia is a lawyer from Colombia, from Universidad Autónoma de Bucaramanga. She also holds an LLM in International Legal Studies from Georgetown University and a Master in Legal Argumentation from University of Alicante. And she's currently a JD candidate at Georgetown University. So let me put Silvia. Okay, so Silvia, welcome to this panel. And to start, I want to ask you three questions that might be or sound big. I'm going to put them in the chat right away, also for people to see them. And the first question, or what I would want you to reflect on, is if you can share why the center started to be interested in this topic of health discrimination of people with disabilities during the context of COVID. We now know that it's not limited to COVID. And why are prioritization and ethical triage discussions relevant for the right to health in general? Then, if you can help us reflect on these two cases, one case that we represent in Chile and the other one in Colombia, regarding the rights of people with disabilities in health emergencies. What are the petitioner's goals and what are we hoping for these legal actions in specific? And finally, if you can share if bioethical arguments or considerations have played a role in these cases. Welcome.
Thank you, Natalia, and thank you to Prospera for the invitation. Okay, I would like to start mentioning that for the Center for Health and Human Rights, health equity is cross-cutting line of our work. And in the context of health equity as a big component of realizing the right to health, of course, we understand that discrimination as a determinant of health is a structural problem that existed before the pandemic, but it was exacerbated and it was deeply reflected in many circumstances in the context of COVID. So aspect of our work, in that aspect of our work, we try to emphasize how biases and stigma against specific groups, including persons with disabilities, in the context of health, had always led to misdiagnosis, sometimes lack of access to treatment, sometimes inadequate treatment, sometimes diminished autonomy or violations to informed consent, and even to violence. So, it's not only about understanding the impacts of biases and stigma and discrimination as a determinant of health, but also how it manifests. And it manifests both in norms and policies, formal norms and policies that can continue to be discriminatory, but also in practices that sometimes are very, very widely accepted. So in that context, during the COVID pandemic, we started to be engaged in two big cases. One case is, and actually two cases that reflect both ways in which discrimination as a determinant of health, discrimination against persons with disabilities as a determinant of health manifests. And one is the problem of triage and allocation of scarce resources in Colombia, that was mainly related to the policies and the regulations or the lack of regulations, and another one in Chile that was mainly not necessarily as a result of formal policies or norms, but as a result of the mistreatment of the practices of discrimination and mistreatment against persons with disabilities. So in the case of Colombia, the main challenge was the protocols. I'm sorry, the protocols or the lack of protocols. I will explain that in a bit, regarding triage during COVID. And in the case of Chile, the main challenge is to obtain reparations, to obtain redress for a family of a person with Down syndrome who died in a public hospital because of lack of adequate treatment. He had COVID and he didn't receive adequate treatment, and there are many indicia that led us to think that it was a matter of not lack of capacity, but it was a matter of discrimination. So those are different type of cases. One was more focused on challenging the structural policies, and the other one is more focused on getting reparations and accountability for that type of discrimination. So I will start with the Colombian case, and Mati already said some of the things that I was gonna start with. So that gives me more time to develop on the specific arguments. But part of the problem that we started to identify, not only in Colombia, but in globally, was that when we started to see in the media, in Italy, in Spain, that there was this in the United States, that there was this dilemma of the last bed or the need for making triage or prioritization. And when we started to dig a little bit more in detail about, well, what are the criteria that are being taken into consideration, or what are the protocols in place, we found four big problems. One was improvisation, a total lack of anticipation of the situation. The second one was lack of transparency about the sources and the criteria that were being applied in practice. The third one was a dispersion of sources, as Natalie mentioned. Sometimes the criteria came from private hospitals, sometimes from universities, sometimes from the secretaries of health. And the fourth problem was the discrimination itself in the criteria that were defined in the existing protocols. And specifically with respect to disability, we found, we started to take a look at different protocols in different states in the United States and different countries in the world. And we found that disability started to be very present as a criteria for making different decisions in the context of scarcity. Sometimes in some protocols, the more like obviously discriminatory, included disability as an exclusionary criteria to exclude the possibility of treatment. That was the case, for example, in Alabama, as Natalie mentioned. Other ones were as a criteria to prioritize, and other ones included disability as a criteria to untie when the short prognosis was similar between two patients. So there were different ways in which, or different impacts that disability could have in the context of those protocols, but the common thread was that disability was present as a criteria. And the other piece on how that disability was present in those protocols is the way, not only the impact that it could have, excluding treatment, prioritizing, or untying, but also how it was present. Sometimes it was very direct. In some protocols like disability or Alzheimer's or dementia or specific conditions, sometimes it was more indirectly or implicit. And I will mention the specific example of Colombia. So that was like the general context, the global context, or the diagnosis that we made when trying to look at how these different protocols were taking place. And we came up in that exercise with the specific case of Colombia. And what happened there, on one side, the Ministry of Health issues some general guidelines, very general guidelines that allowed, in very general terms, allowed hospitals and doctors to take into consideration different criteria, in which they included, for example, long-term survival considerations or functionality. And then, because the Ministry of Health gave a big margin of discretion to different authorities in different regions of the country and to different hospitals, in other regions of the country, we found more specific protocols, one in two specific cities, one in Medellin and the other one in Bucaramanga, in which you could find as criteria for prioritization or untying long-term survival considerations, functionality, the potential need for support in the future when the person leave the hospital. So speculation about potential needs for support in the future. So we said, well, they don't say specifically disability, but they are indirectly targeting persons with disability. So there were more subtle ways in which disability was present, but disability was present in those criteria, especially when you give a subjective consideration of the functionality of a person in society, like social functionality, and also, of course, the need for support in the future. So we started to we didn't go to the judiciary since the beginning. We started with trying to work directly with the Ministry of Health. We sent some requests of information to understand how these triage exercises were taking place in the country, and expressing some concerns about the criteria that were already in place, or the margin of discretion that some authorities and hospitals had based on the guidelines of the Ministry of Health. We were not successful in trying to reach the Ministry of Health at that moment, so we decided to move forward with the support of a group of people persons of older age and persons with disabilities who wanted to pursue a judicial action to challenge those protocols that could impact them potentially if they were to be if they were to be infected with COVID, and of course subjected to a situation of scarcity in their specific cities and regions. So with País, Federico is here with us from the Universidad de los Andes in Colombia and the O'Neill Institute. We provided legal support to this group of persons with disabilities and older persons who wanted to challenge these protocols judicially. So that's what when we presented our action de tutela, which is a constitutional action to provide to protect fundamental rights in individual cases in Colombia, but that in the context of Colombia can result in structural reform in orders on the part of courts, particularly the Constitutional Court, to make structural changes in policy, in norms, etc. So what we wanted with the acción de tutela, or what the plaintiffs wanted, and we provided legal support for that, were many different things. One was first to bring the topic and frame the topic as a human rights concern, because up to that moment, it was framed as a matter of only bioethics or a matter of public health, but the human rights piece was absent. So we wanted to use this constitutional action to frame this as a matter related to the right to life, to the right to health, to the right to non-discrimination. And that's a big part of the challenge in this context, that the lack of bridges between public health, bioethics, and the legal world, and specifically human rights. So one goal was to frame this as a matter of human rights. The second one was to say we're not only challenging here the criteria, the specific criteria, but we're challenging a whole policy in which there is a lack of anticipation before the scarcity, before the pandemic, lack of anticipation, not only with enough availability of goods and services, including ICU beds, and a diagnosis of how prepared are countries to face a pandemic in terms of availability of health goods and services, but also in terms of policies to face situations of scarcity. So lack of anticipation. So we wanted to make sure that there was a legal obligation established by the Constitutional Court to anticipate these circumstances, to prevent discrimination in these cases. The other one was prioritization, as that prioritization was established as a measure of last resort, and only acceptable for the least period of time possible. The other one was that the need for both procedural and substantive safeguards. In terms of procedural safeguards, transparency, participation in the construction of this type of policies, accountability, and on the other side, and participation, of course, of the groups affected by these type of policies. And I think Federico is going to discuss that a little bit more. And the substantive safeguards, including, of course, non-discrimination and the prohibition, the explicit prohibition to use directly or indirectly, or explicitly or disability as a basis for prioritization. So those were the main objectives of the lawsuit. I think we're going to, most of them we are very satisfied with the decision of the Constitutional Court. It addressed most of these issues and made an explicit order to the Ministry of Health to regulate and establish uniform and clear criteria that are non-discriminatory in order to anticipate for future public health emergencies that may require prioritization or that may create scarcity of health goods and services. I know that Federico will discuss more in detail the implementation and other aspects of the decision, so I will not go into more detail. That was the main concern that we had in the case. And I would like to mention something about bioethics and how we have faced in the context of the litigation of that case, a constant obstacle of people bringing bioethics, alleged bioethical consensus to somehow saying the human rights has not a say into this. This is a bioethical matter, and this has been already resolved in the literature. This has been already resolved in this discipline, and we have been trying not only to bring the human rights discourse to the discussion, but also to challenge the idea that those consensus actually exist, because we have found many sources, many alternative sources that challenge those alleged consensus that disability can be, or age can be, long-term survival considerations, and those type of issues could be actual acceptable considerations to take into account when doing prioritization criteria. So a big part of this, as I mentioned before, has been to try to build bridges between bioethics and human rights, and try to challenge the idea that these issues have been already decided and resolved in the context of one specific discipline, in which we know that also it's not the case that there is a consensus in terms of these issues. And finally, just to mention, I know I'm over time, in 30 seconds, I will just mention that the other case, the case of Chile, as I commented before, the main idea is a civil case, a civil reparation case, in which what we intend is to obtain some accountability on the part of the public health authorities because of the mistreatment of a person that was deprioritized, not because of the existence of protocols, but because of the practices and the very accepted practices in the hospital. And in a case in which a number of biases against persons with disabilities had an influence in the result that this person died died of COVID without adequate treatment. For example, some supports that he needed were not even intended because they assumed that he was not going to be a supportive patient, which is one of the biases that is very common in the context of disabilities. In the case, there was even a consideration of a person who said, well, the most persons with Down syndrome don't outlive more than 40 or 50 years, so you must feel lucky that this person already lived these years. And there were many situations of violence and discrimination, more factually related to a specific treatment that this person received. And hopefully we can get some accountability for that. It is a case that is more challenging in terms of evidence, because discrimination in these places, in these situations, usually is not that explicit, that clear. You don't have documents that clearly establish the disability was a factor here. So hopefully we get the courts, so we convince the courts that they need to be flexible in terms of evidence and take into consideration indicia for accountability for discrimination in this context. Thank you.
Thank you so much, Silvia. And now we're going to let Federico speak specifically about the Colombian ruling. But first, I wanted to show you really fast some of the faces of the people that participated in the Colombian action. Of course, it was during the pandemic, so we met on Zoom, but these are some of the 25 petitioners. Some of them are here, some others couldn't be there, but they are very diverse group of people that were feeling at the moment that their rights were at threat, and they were feeling like real moral. They were anxious, they were afraid, because they knew that if they got sick, maybe they wouldn't be treated because of their disability or their age. So now I'm gonna give the space to Federico. Federico is also Colombian. He's a Colombian human rights defender and a lawyer specializing in justice, victims, and peace building. He's completed his master's degree in Latin American political studies. He has worked with the legal clinic País, which in Spanish is Programa de Acción por la Igualdad y la Inclusión Social, which is part of the Universidad de los Andes in Bogotá. He has been there since 2016, and he's currently the director. Federico has worked on supporting organizations and of persons with disabilities and states entities for many years. He has provided legislative and regulatory support and generating and accompanying international advocacy actions before the United Nations systems. He is a member of the drafting committee for the reform of legal capacity regime in Colombia. And he has also participated as an alternate commissioner in the Commission on Human Rights and Peace created by one of the agreements on the Havana Peace Agreement in Colombia. He's currently the technical secretary of the Colombian Coalition for the implementation of the CRPD and the Alliance for Legal Capacity in Colombia. So Federico, welcome to this space. And following up on Silvia's exposition, I wanted to ask you if you can help us share some lessons learned from the Colombian litigation and the actual Constitutional Court decision regarding the regulation of ethical triages during health emergencies in the country. We know that this is a unique decision, and we all only know about another decision in Germany, but this is one of the only decisions in the world, judicial decisions, that have addressed this issue of ethical triages or the dilemma of the last bet. So this is an actual historic decision. And if you can tell us, what can this litigation teach other countries for future pandemics or public health emergencies concerning the rights of people with disabilities? And the other question, which I think is crucial, is what challenges have you faced during the implementation period? This decision is from 2022, so we already are in the implementation period. And why is the participation of people with disabilities in the construction and implementation of these decisions so crucial and so important for the process? I'll leave you with Federico.
Thank you, Natalia. Thank you, Joanne. Thank you, Julie, Prospera, for the invitation. It's for me a pleasure and an honor. I'm very happy to be here with Silvia, with Natalia. This has been a very difficult implementation process since the ruling, but we will get to there. Before I answer the question, I would like to recognize the importance of this conversation, and also I'm very moved by the initial words of Joanne, so that were very, very, very moving. And I think that talking about this in 2025 will let us not only reflect on the lessons of the COVID-19 pandemic around the ethical and legal actions that were made, but also to use these actions to think and reflect of how to build or reconstruct the legal system, the institutional structure of provision of health services, where no persons, regardless of the age of disability, is relegated to the margins of survival or who seeks to justify himself as a citizen in order to be cared under equal conditions. So in having said that, and now answering your questions, I think that I will emphasize on the fact that, as you said, Natalia, this is a very unique and important case. Not only, I think, for Colombia, but as you said, to the world, but especially I think that in the history or recent history of the Constitutional Court in Colombia, I think that is one of a kind. By the different things that Silvia just said. But maybe just bringing to the spotlight some of these reasons. I think that the first one has to do with the pictures that you just saw, that Natalia showed recently, because I think that this case proves that the organizations, the legal clinics, can be supportive in democratizing justice and helping a lot of people, but putting them in the first place. So in this case, as it was said, this tutela was filled by 26 individuals over 60 years old and or with disabilities, maybe some of them with chronic illnesses. But I think that this is a very important case because it also underscores the critical role of accessible judicial avenue for vulnerable populations but reinforcing also the idea of legal capacity recognition and access to justice for people with disabilities and elderly people. We have in Colombia, as Natalia said, a law of 2019 that recognized in equal conditions the legal capacity of persons with disabilities, but we are part also of the Inter-American Convention that recognize legal capacity for elder people. And I think that this is a very important case that shows the action and the active decision of the people, because as Sylvia said earlier, the things that were required to the court were the things that the people wanted, and the support was only just to get it into the language of the law. I think that that's the first one I think that I would like to put into the spotlight. The second one, I think that this is a very important precedent for ranking first the substantive justice over formalistic barriers, because the court condemned the other lower courts dismissal of this case by that were made by especially procedural grounds, reaffirming that fundamental rights violations cannot be trivialized through technicalities, and even in this aspect, even though the court stated that by the time it was issued the decision, that it was 2023, the risk that began all this motion no longer existed, because in 2023 we were having lower ICU bed occupancies, the declining COVID cases, and lower mortality rates. But still, the court deemed it necessary to issue a substantive ruling to advance the understanding of equality and health rights in context of scarce medical resources requiring prioritization. So therefore, the court proceeded to rule on the merits to prevent future harm. I think this is a very, very important thing. The third thing that I want to address is the integration of intersectional analysis. The ruling that's dissected how age, disability, and health issues intersect to compound discrimination, in this case around global human rights standards, in the cases of access to health services. And this intersectional lens is vital to addressing the layered vulnerabilities that made the court take that decision. I think the other question that is important to take into account is, I think it is also an example for getting clear the balance of medical autonomy with human rights, because the court used a lot of its precedents to held that medical autonomy is not absolute and must align with constitutional rights, bioethics, scientific evidence, and therefore that results also in the rejection of an utilitarian triage models that sacrifice maybe equity for efficiency, but also during the pandemic, the court stressed that medical autonomy is preserved when practices adhere to human rights frameworks, and thereby it could also help to mitigate moral dilemmas for healthcare providers. And in this specific case, the court have to work around two legal issues. The first one was around if the Ministry of Health would violate or had violated the rights to equality and the other rights that Sylvia mentioned on these people by refusing to issue a binding act establishing legal criteria for prioritization in these exceptional scenarios. But also, then the second one was that if the ministry violate those rights and disability by the general recommendations by failing to clarify when and by whom such protocols should apply. So that was the specific legal issues that the court has to work. And the court concluded that because of that omissive conduct, the Ministry of Health violated that fundamental rights and decided to overturn the lower court rulings, which had declared that the tutela was inadmissible, and instead ruled that the case is now moot due to a supervening event. And the last thing I want to mention in this regard is that I think that is also example, just something that Sylvia said, is that natural remedies with the participatory mandates that the court established. Because the court ordered specifically the Ministry of Health to initiate within 10 days after the issue of the ruling to promote the necessary regulatory adjustments and issuing a binding act establishing this technical, ethical, and legal framework for prioritization protocols in these exceptional circumstances, ensuring participation. And that's the next thing that I would like to begin with. But in short, I think that this case is a very important case because it established the necessity to prevent normalized discrimination in emergencies through anticipatory rulings. This is very important because we don't know when, again, we have another thing like that. I don't know if you have seen the news, but for example, Bogota is possibly one of the cities that is going to be erased by this asteroid that we don't know where he's going to get hit. So there is another very viable possibility in the next years, and we are not prepared because of these things that we have just been talking. The other thing is that definitely centers intersectionality in the rights-based adjudication in the cases. It brings the things around transparency and accountability that generally is around the money issue, but not especially in the providing the health services by these things, and also the necessity, as Sylvia said, to engage the bioethical, ethical training for healthcare professionals with the human rights movements. And I think that this ruling, in summary, represents also eventually a counterweight to some regressive global trends that we are having. Just today, in case you don't know, one of the legal documents that was raised by the Ministry of Work in Argentina established again a lot of discriminatory language around people with disability to access of social security things, regaining again words like idiot, dementia, in terms, but that in those cases there was a lot of conditions around entering the social justice thing. So I think that this court with this case puts the thing around the project of radical inclusion in the healthcare services. I think that's the best. And to end the intervention very briefly around the challenges that we have faced, I think there are a lot. It would be difficult to summarize, but it has been complex, difficult, and a very slow process. I consider that the process has not complied with the standards used by the court, and as today, we are in a state of failure to comply with the main order of the decision. To be clear, after the ruling was issued, Pais and O'Neill participated and have been participating in the process of compliance with these orders. But in terms of time, let's remember that the court established that within the next 10 days of the ruling notification, that was the 4th of July 2023, the Ministry of Health had to begin the procedures to develop these regulatory adjustments. And therefore, the process had to begin on the 14th of July of that year. And that in that process, the ministry must ensure non-discrimination and maximize the public participation and transparency, adopting a timeline for issuing the act, and also order that it has to establish the ministry a calendar that allows for the issuance of the act within a period that does not exceed 1 year following the notification. The year was completed in July 2024. So in this sense, the main complication is that today the Ministry of Health did not and has not complied with the orders given by the court. Now, and this thing is one of the situations that has been arise, that one could point that, as the ministry did at one moment, this is an absolutely important matter, and consequently, it will take the necessary time to issue to meet the medical and consensus standards around the scientific community, etc. And that require times. But also this presents many specific difficulties, because the first one is that thinking of the need to have a prudent time to work, the work started very late. The first invitation to participate arrived on April 4 of 2024, almost 7 or 8 months after the notification of the decision. And in addition to that, the invitations did not reach people other than the organization that support the legal process. And since then, we have been having 5 deliberation sessions. The last one was held in December, and at that last meeting, a compromise was made by the ministry to share the draft of the regulatory document, and to this day, we have not received any response by the ministry. And in addition to that, all the things that Silvia mentioned around the bioethical human rights discussions that has not to be taken into account, and this made the methodology and the questions very difficult for those who did not also come from the medical sector. And just to finish in relation to the participation, because here we have to have the participation of the people with disabilities and also by the elder people. And only one participant was a colleague with disability, which is also a member of the legal action. Our colleague Rafa Pavon, who is in a very wise manner entered those discussions, but it was by our request, not incorporated by the ministry. And other people that have been around these discussions, also a colleague with disability that is in charge of the disability issues in the Ministry of Equality in Colombia, and the Ombudsman office were brought to our request, not by the direct invitation of the ministry. And this is a very limited way to see the process by the ministry, because participation is also a binding and a mandate by the Constitutional Court in different rulings, by even the law regarding to health services, but also by the CRPD and the justice system that we have around these things. Since 2007, we have a national disability system that works as an organism of direct participation and representation, and is the consultative body for excellence in matters related to disability that also has not been invited. So we're having a lot of difficulties, and in this sense, it has not complied, the Ministry of Health. It has not complied with the participation and the maximum participation. So we are in a very difficult moment in that scenario. And I think I will let it there.
Thank you so much, Federico, for your explanation. I want to add something connected with the reactions that we have been seeing from the people in the minister and from like the general perception. Is that some people, the minister has argued that this is a topic or a matter of medical autonomy. And that was an argument used during the litigation, and an argument that has been used during these technical spaces where we have been debating how we can implement this decision. And we have analyzed and really discussed this, because we believe that they are confusing medical autonomy on specific medical decisions that, of course, are part of the medical autonomy and of the lex artis, with having clear guidelines for these tragic decisions, as I said in the beginning, that should be exceptional and only in cases of emergency. And this should be part of a public policy that involves many voices, not only the specific doctor or physician voice, but the discussion of the public in general, of bioethics, as Silvia was saying, with human rights, but also people that are directly involved in this. That's why we're very insisting on having people with disabilities and older people participating in the construction of these guidelines. That hasn't been possible, but we think it's an interesting topic to say that this ruling violates medical autonomy, what we understand about medical autonomy. And I think this is a really important and interesting question for bioethics in general. I don't know if that's something that you have seen in your context, but that's something like a general reaction that we have had from the health perspective, from health professionals' perspective, this is violating their autonomy. And it's curious because the court said that this is helping medical autonomy because it will give physicians that were struggling with these tragic choices a clear guideline. And it was going to help them reduce that anxiety and that moral questions that they have when they had to decide which patient should I choose in a context of extreme scarcity. So it's promoting and improving their ability to make their job and not violating their autonomy. So it's an interesting counter argument that we have been seeing, and we just want to mention that. So now that we are done with the two panelists, we would like to open the floor for discussions, comments, questions that you might have about the cases. I'm also leaving here in the chat. There are two links if you want to know more about the Chilean case, the Oscar Walter case. We have a press release and more information about the case, and also about the Colombian case. We have many press releases and some like summaries of the decision if you're interested. And yeah, I will leave the mic for anyone that wants to share something or ask something to our panelists.
Thank you, Natalia. Someone sent me a question in direct message, and I'm not sure if they want to get off mute, but I'm happy to ask it on their behalf. So they said, I'm thankful for all the work being done for discrimination against those with disabilities. This is excellent work. My question is, how do we dismantle past discrimination and present discrimination in the form of colorism? For example, for Black women in particular, there is an extreme history of skewing data and ignoring the suffering of Black women, it resulting in disproportionate mortality rates for them. For Black Latinos, for example, they have always been treated separately. So how do we make sure that we don't perpetuate that harm and actually do the work of remedying that abuse and discrimination? That's a loaded question, but go ahead. Anyone can take a stab at it.
Sorry, I
Or
was waiting to ask that question the whole time. So if it was a little layered, I was waiting for it.
if you want to expand, George, it's your mic is open.
So Joanne, can you actually I'm trying to copy paste it to put it into the other chat, to put it into the main chat. But basically I wanted to say thank you for your excellent work on behalf of those with disabilities, for sure. But that's just one kind of discrimination. So as we're forming ethical standards like that, standing against that kind of discrimination, how do we make sure it carries over to other kinds of discrimination, particularly colorism? Because for Black women in particular, that ends up impacting mortality rates and life and death. So because it's so extreme, how do we make sure that that doesn't apply to past data? Like we make sure to sift through that. But how do we make sure as we gather new research, we don't perpetuate that kind of skewing of data as well based off that kind of discrimination?
Well, I can try. Well, it's a very difficult question, and of course we have been focusing on the issue of disabilities in this webinar, but we have also in that context of understanding health equity in a broader way, and not only in terms of equal insurance or universal health coverage, but also to understand the specific realities of specific groups in the context of healthcare as a part of health equity is something that we have been working on. And specifically, we have worked in the context of biases and stigma and how they take place and how they are a symptom of those subordination historical dynamics in societies with respect to Black persons, Black women, and how intersectionality takes place. So I just wanted to share a little bit of how we approach the legal work, trying to make it visible that it's not enough to say there are biases, and we know what are those biases, for example, in the context of, or that affect Black women in the context of healthcare. We know what are those biases, but if we don't visualize the impact that they have, the specific impact that they have in actual practices, constant practices in the context of healthcare, policy will not change, because in many instances, all those biases and stigma are part of what is being taught, are part of what is being constantly repeated in medical education and medical practice. So one piece of the question is so big, but one piece of what we have been trying to do with specific groups and specific intersectionalities, as the one that you mentioned, Black women, is to understand what are those biases, name those biases, and name the specific impacts that they have. Because you can have a policy that says we're not going to discriminate, but if you don't understand in actual practices how that discrimination takes place, you won't be able to make structural and policy changes. So that's why, for example, in the context of Black women, one component is one aspect is sometimes misdiagnosis. Sometimes it is a matter of violence and mistreatment. Sometimes the implications that they have may be related to assumptions about adherence to treatment, so how it impacts the treatment that people give, and how even assumptions and considerations about the thickness of the skin of specific groups that may impact even, for example, pain relief in the context of healthcare. So it is part of our work at the Center for Health and Human Rights is understanding health as having three dimensions, at least: dimensions of autonomy, dimensions of prevention, dimensions of healthcare, and trying to understand how discrimination, structural and systemic discrimination for specific groups, impact in all those different components. Using again the example of persons with disabilities, one of the biases that is very common is that, of course, they are not able to make responsible decisions, so that impacts consent, that impacts autonomy. But some other times it is a matter of fragility, and that impacts the easiness in which doctors tend to give up in terms of treatment. So a big part of this work of using structural and systemic discrimination as understanding it as a determinant of health and as a big part of health equity includes understanding how biases impact specifically and the specific impact that they have in day-to-day access to healthcare for specific groups. That's something that I wanted to share because we have been doing a lot of literature review and understanding of how biases of specific groups impact healthcare. And what we've seen is that there is a lot of theoretical discussion, but there is a lot of less understanding of how the specific impacts that they have in practice. And something else that I wanted to mention was about research and data. As you mentioned, a big part of health equity is also not only closing the gaps between in terms of health coverage, but also to doing research and actually overcoming the big problem of discrimination in research, and also in terms of diversity in access to healthcare, because the lack of diversity in med school, lack of diversity in the medical force also has a big impact in discrimination. So this is just to say that this is a big puzzle that it's composed by many, many factors. It's a multifactorial problem, but we need to be able to understand what are those pieces, what are the impacts that they have, and what are the policy interventions that are needed for each of those components of that systemic and structural discrimination that specific groups face.
Federico, I don't know if you want to add something.
Well, I think that maybe because of the example that I think that this case brings to the scenario, I will put all the bettings also, as Silvia said, in a multi-strategic action, but also the one that ensures the most possible participation of the people that are directly affected. I want to just put a case. In several years ago, we have a situation with a, a woman with disability that was from an indigenous community that was getting a medical exam with their gynecologist. But the bed, on all the beds in the hospital were not accessible for her because never the hospital received a patient with disability to do that kind of exam. So it shows that, as Silvia said, if there are not people with the necessities in the places that are providing the services or taking the decisions around how the services has to have done, or take into account in different scenarios of participation what are those necessities, it is very difficult to have that change. And of course, the judiciary scenario is a very important one. But one of the things that we have been talking with Natalia, with Silvia, with O'Neill, has to do with eventually if we have, for example, in this case, a very good binding act, the professional of health services are going to apply it, then we have to be working around a lot of pedagogy and work with the situation, but especially that they can hear the persons with disabilities and the elder people, in this case, to show them that those criteria that are very subjective and could land in discrimination has and had effect on real people. Because I think that one of the things that I have seen, and my impression is that they're putting the apparently authority of the scientific things like they're untouchable, even though, as they say, there are a lot of references that could come across to and reject those things. But it's a very hierarchized hierarchy. I'm sorry for my Spanglish here, profession, but so it's very difficult. So we have to have also very important people that could talk bottom these things. So yeah, that was just one thing.
Thank you. If it's useful, George, there is a really interesting decision from the Constitutional Court of Colombia during COVID, talking about traditional midwives in the Pacific of Colombia and how they were discriminated against during the pandemic because they are mostly Afro-Colombian midwives. It's a traditional profession that has not been recognized by the state, showing the structural racism also. But they were not recognized as health professionals during the pandemic, so they were not given any economic incentive or any protection during the COVID pandemic. So they filed a tutela, like just as the one we discussed here, and they won. And the minister said, this is an act of discrimination based on race, and the health system, the minister needs to incorporate them as health professionals. Because if they don't do this, it's discrimination, it's racism. They haven't complied with that decision either. But that's just an example of how we saw litigation being used to improve or to show discrimination during this specific time, but it led to more systemic decisions to improve health in general. I can share the decision if you're interested, but that's another example that I think could be useful for the conversation.
Yeah, this is so great. And it's interesting to see the conversation between Latin America and what is currently going on in the United States right now. There is a lot of violence, structural violence, and as Sylvia lifted, this is not an isolated issue. It's very multi-layered, it's very complex. One area bleeds into the other, especially when we're thinking about policies that really honor people, not just institutions. And when we think about how policies can be weaponized to further marginalize. And if you don't know the language and if you don't understand the nuances, it's very easy for you to agree because it sounds good, but actually underneath the surface, there's a lot of in between the lines. Um, I want to thank you guys so much for this very important conversation, very timely conversation. We're seeing a lot across our landscape right now with the defunding of programs and the violence that communities are experiencing with essential resources being pulled. Today, I just read an article about how 504 plans and IEP plans are going to be pulled out of schools for students who are, have special learning needs. And that's something that also falls under this umbrella of discrimination within the context of prioritizing public health resources. Um, Thank you again, Federico and Natalia and Sylvia. We hope to keep the conversation going. We want to uplift that there is a feedback survey. Our Julie so graciously put some important links in there. You can find the link to the O'Neill Institute. Please engage their website and learn more. And also, if you have a chance, please fill out the feedback survey. This is a pilot, so we want to hear from you and hear the conversations that you want to continue engaging as a community. And lastly, you will see a link for RSVPing for our next session. Our next session will be in person. It will be at the church where we host our annual conference, Bethel AME in Jamaica Plain. And it will be a discussion on Afro-Latinidad identity within the spiritual context in relation to public health. Thank you all for attending, and we hope to see you again in the future. Ciao.
Thank you.
Thank you, Natalia. Thank you, Federico and Sylvia. And I will follow up with you guys offline. Natalia, you and I have to also follow up offline. So have a good evening, and thank you so much for your time.
Thank you, Joanne
Thank you very
and Julie.
much.
Thank you. Ciao.
Everybody.
Ciao. Julie, you can stay on if
Yeah.
for a couple minutes.
Definitely. I wanted to leave the chat open. Do you want me to continue recording?
Yeah, let's close out the recording for sure, and let's make sure that we download